Good morning, everyone. We are going to discuss another issue about COVID management, the psychiatric issues associated with the COVID, and even otherwise, even if it is not with the COVID, and how to handle those issues on the bedside. So, I request Dr. Vijay Krishnan to please initiate the session and uh, give us an idea about how to manage it on bedside. Although the time allotted is very small and the topic is vast, but we would always get a glimpse of the things what all is required for managing psychiatric issues on the bedside. I hand over the session to Dr. Vijay Krishnan.
Uh, Thank you, Dr. Puneet. I hope I'm audible. Good evening. Um, Welcome. Thank you for coming to this session to listen to me talk about this. I'm just going to share my slides. Please do let me know if they're visible. Uh, as Dr. Puneet, I hope this is
Yeah,
my slides are showing up.
yeah,
Right.
visible.
So this is the topic that I was allotted, and I thinking about it, there seem to be a number of ways of approaching it. What I've chosen to do is to talk purely from the perspective of the kind of issues that we're likely to see in an inpatient setting, in with the kind of patient population that we are seeing. Uh, I have chosen to speak about two issues in detail. One would probably be related to um, patients in typically in high dependency or an intensive care setting. That would be delirium or agitation. And the other category are of the kinds of mental health symptoms or psychiatric symptoms that are likely to occur in hospitalized patients across the board. There are a number of other psychiatric issues that are identified, which probably do deserve some attention. But for want of time, I've chosen not to focus on them. If there are questions at the end related to these, I'm happy to take them at that time. So those would be related to the use of psychotropic medications and how they interact with both COVID and treatment for COVID, the psychotropic effects of specific treatment modalities, specifically steroids, which we are using quite frequently in this population. There is the category of long COVID that is much discussed in the West, and of course a number of other issues which would sort of start overlapping quite significantly with general psychiatry or consultation liaison psychiatry as a whole. So, in relation to delirium, so delirium is a clinical syndrome that is characterized by an acute or a subacute onset. It is variously called an acute encephalopathy, an acute confusional syndrome. It is a condition that is quite frequently seen on inpatient units. Unfortunately, it is quite commonly missed. I would suspect that this is a condition that occurs quite commonly in the population. We do get a few referrals for assessment of delirium, but given the importance of this condition and how much it can impact care, I thought it would be worthwhile to draw the audience's attention to this condition. So. Uh, as we said, delirium is an acute confusional state. The characteristic symptoms are of a person who has a fluctuating sensorium, in the sense that the person becomes alternatingly agitated or drowsy, seems to be quiet at times, becomes agitated, tends to get lost, tends to not follow instructions or not recognize where they are, or what is expected of them. There are specific situations in which I would want us to be particularly careful and assess for delirium. This would be in among patient populations that are older, patients who are generally more unwell. So, for example, in patients who are going towards ARDS or towards severe pneumonias, it could very well be that delirium is the first sign of a deterioration that will be picked up by other clinical signs. later in the course of time. It's more likely to occur in patients who have comorbidities. So when you see a patient who has multiple recorded illnesses or who is on multiple medications, that would be a reason to suspect delirium even more than in general. In addition, there would be situational factors. As I said, this is likely to be a patient who seems to be unexpectedly or unexpectedly quiet, or more quiet than they were the previous day in rounds. They equally may be the opposite, that they're becoming more agitated. It could be that they're not able to recognize where their bed is, or they're not able to get to the washroom if they are ambulating towards for their own toileting purposes or anything else. It is also quite likely that the first presentation of delirium would be with this question of a person becoming resistant or non-compliant with what they are expected to do for their best care. That would be when you have a patient who throws off their NIV mask or throws off their hypronasal cannula, starts desaturating because of that, starts pulling out their nasogastric tube or tugs at their IV access. They may become restless and not comply with instructions to go through with proning. And in general, they may be described in the clinical notes as not following commands, not following instructions. And this is a situation where it probably makes sense to take a step back as a clinician and consider the possibility that this is not because the person is just not understanding because of not understanding the seriousness of their condition, but because of a neurological or a neurobiological change, they are at that moment lacking the capacity to comprehend the seriousness of the situation they're in. The approach to both of these would possibly be substantially different. And therefore, it is necessary to maintain a low threshold of suspicion, especially in the ICU setting, for delirium as a possibility rather than patient-related factors alone. The condition itself, the hallmark of delirium is an impairment in attention. So attention, as we look at it as psychiatrists, could involve the ability to focus on a particular stimulus, to focus on a doctor, or focus on a particular task. The ability to sustain that attention in the sense that the person may lose interest very quickly, or they may be unable to shift attention appropriately, which means that they may become very focused on something that's irrelevant, or at the opposite side, they may shift their attention so easily that they become distractible and do not persist with any task. The second, as we mentioned before, is a fluctuation in consciousness level. This is where you see a person who seems to be quite agitated, quite alert looking at one time, and let us say an hour or so later, the person may appear to be sleepy, drowsy, or generally less active than they were previously. This fluctuation in consciousness level also manifests as an alteration in sleep-wake cycle, which may be easily picked up, where the person seems to be very active and awake at night, but becomes very sleepy through the day. What is usually picked up by clinicians when they are present are the presence of psychotic symptoms. Psychotic symptoms, as I'm sure you know, are hallucinations, which is hearing, seeing, feeling things that are not there. So the person may start complaining that they see shadows or that they see people around them. Or they may have delusions. Delusions would be false beliefs. In this case, the most common category of delusions are likely to be fear-provoking delusions of being harmed by somebody, or that the doctor's instructions are intended to make them more unwell. These symptoms are more easily recognized than others because they are quite clearly abnormal. They are also likely to put the patient directly in conflict with the treating team because the patient may lash out or become aggressive while acting on their psychotic symptoms. The other symptom that's very commonly assessed for, but is not necessarily a symptom of delusion, of delirium, in the sense that that is possible to make a diagnosis of delirium even in its absence, is the symptom of disorientation, by which we mean that a person is unable to recognize their surroundings appropriately. So this may become that they're not able to recognize the time of day. They may think that it is morning when it is actually in the afternoon or in the evening. They may be unaware of where they are, which could mean that they say that they're at home when in actual fact they are in the hospital. Or they could be disoriented to person, which means that they may misrecognize. Typically, people with delirium would make mistakes in recognition rather than being unable to recognize. So they may therefore know that this is someone familiar to them, but they may not be able to say whether this is their daughter or their sister or their wife. Mistakes of that sort would be a manifestation of disorientation to person. I've drawn these arrows because it is usually in this sequence that orientation is lost. Orientation to time is lost before orientation to place, which is lost before orientation to person. The other manifestation of delirium is in terms of the person's speech. So rather than having a coherent dialogue where questions are answered in an appropriate sort of way, the patient may answer with statements that are irrelevant or that are not connected to each other. So the person may start off right and then gradually get lost. They may repeat themselves, and these again are likely to be picked up by careful clinicians if when they spend time at the bedside. The other is, and this I am drawing your attention to this because this again is a problem that is likely to affect care. Patients may not be able to remember things that have been said around them. They may not remember their medication. They may not remember their meals. They may become dependent on caregivers for all these to sort of coax them or persuade them to take meals. Typically, the memory loss is only for things that are happening in the here and now. So things that have happened 5 minutes ago are likely to be forgotten far more easily than things that happened a few years ago. So the patient may well be oriented to or may remember events of the past while being unable to remember what was going on in morning rounds or what instructions they were given at the time. All of these symptoms are important to remember because all of them affect how you would approach this patient who has delirium. The formal assessment at the bedside particularly in a general medical setting, is by use of what is called the confusion assessment method. This is a simple sort of assessment tool. What I've put up here is a modification for use within the ICU, particularly for patients who may not be able to respond verbally. But the principles of assessment are the same for other populations as well. So what you're looking for, I've said, is an acute onset or a fluctuating course, which is a change in the person's mental state. So if you've seen a person longitudinally, that would be helpful to recognize whether that this person is different from how they were the previous day. Attention, which is assessed by asking them to pay attention to, in this particular case, by what's called a vigilance test, where they have to indicate every time they hear the letter A. The third is what's called an altered level of consciousness, which is what we were talking about in terms of agitation or drowsiness. This RASS is the Richmond Agitation Sedation Scale, which is another instrument that's used for this. But you don't really need to use that. It just requires that the patient's overall restlessness or sleepiness is checked for, and you make out whether the person seems to be different from before. The fourth feature is of disorganized thinking, which here is tested by use of various comprehension tests. Again, if you're using this, you can make a clinical assessment of this by checking how the person seems to be responding to questions, whether they're able to make a coherent response or not. So the requirement to make a diagnosis is that the colors seem to be not very visible. So the tick marks are showing that that both feature number 1 and feature number 2 must be present, and one of features 3 and 4 must be present. So it requires that 3 of these should be present in order to quickly come to a diagnosis to an impression of delirium. The assessment usually takes 5 minutes or less. The assessment can usually be carried out by nursing staff or paramedical staff on the hospital, and it should be repeated in order to make out whether the person is getting better or worse. The management, the management of delirium is, in brief, it must be made very clear that delirium is not a psychiatric condition in the sense that it is usually a feature of an underlying medical illness. I've listed out a series of common medical illnesses that are likely to be present in this population. So the common ones are sepsis, electrolyte imbalances, metabolic changes, by which I mean uremia or hyperammonemia or hepatic encephalopathy, hypoxemia, very important given that we are assessing patients who are suffering from a respiratory condition, hypertension, hyperperfusion of any cause, which could be a cardiac failure or shock, hypoglycemia, or withdrawal symptoms, particularly from alcohol or from sedative hypnotics, which could usually in our patient population, that would usually be a benzodiazepine. It is usually multifactorial. It could be many small things that cause delirium rather than one large deficit. The other thing to be aware of, as we said, this is common in a population that is likely to be on multiple medications, particularly medications with anticholinergic effects or sedating effects can produce delirium. Equally important for this population, one of the very common side effects of using higher doses of steroids, even for very short durations, could be agitation, which could progress to delirium. So one of the things that you should be aware of is that we are giving our patients agents that could increase their risk of having delirium. Given it is obviously a risk-benefit decision as to whether the steroids should continue. Steroids should typically continue. But given that we are continuing steroids, we should probably try to mitigate their side effects or prescribe some treatment that would take away the impact of delirium or agitation. In continuation, because patients with delirium are confused, have limited attention spans, it is usually a good idea to speak to them loudly and in clear sentences, and to repeat instructions and to provide them with information that would help them to recognize where they are, which is what is referred to as reorientation. Patients may require some level of restraints. It is usually a good idea to use the minimal amount of restraint that would be helpful to keep the patient well and prevent them from harming themselves. Boxing glove bandages or bed rails could be useful to prevent injuries or falls. It is also important to recognize that our natural approach in this sort of a situation where a patient is trying to walk away from their bed and might fall down is to get angry with the patient. This could be perceived as a confrontation by the patient, and they may react with agitation, aggression, and an increase in resistive behavior. So perhaps we should again take a step back, consider that this may be something that's happening outside of the patient's control, and try to convince them or persuade them in a quieter sort of way rather than try to force them to do things. The pharmacological management, is part of the management. It is not the entirety of management. I would like to make it clear that these medications do not treat delirium. It is not necessary to prescribe these medications for everyone who has delirium, because they do not shorten the course of delirium or treat delirium as such. Our target should be to minimize or to abolish agitation to the extent possible, while avoiding sedation and potentially increasing the person's ability to pay attention. The agents that I've just listed, a couple of agents here, haloperidol and olanzapine are usually available in hospital supply. They are available for both injectable use and for perorally or by nasogastric tube. Usually, we would start at a very low dose, which is given frequently, and increase the dosage over time to the part to achieve the target that we're talking about. Typically, patients can receive additional STAT or SOS doses in addition. In this population, we don't have to worry about respiratory depression with these agents. It is far more common for patients to become sedated or to have a QTC prolongation, which will be picked up on an ECG, or to have a dystonia, all of which you would have to check for. And this is the reason why we would usually start with the lower doses and gradually increase. Right, I'm sorry, I don't seem to. Okay. That's all that I wanted to talk about in terms of delirium. If there are questions, I can take them at the end. The other kinds of symptoms that I'd like to talk about very briefly for this population are the kinds of psychiatric symptoms that are common in hospitalized patients. The most common psychiatric symptoms in hospitalized patients are the same symptoms that are common in the general population. It is just that the frequency of those symptoms and the severity of those symptoms increase. The symptoms that are most commonly seen are anxiety, insomnia, depressive symptoms. Some patients may have suicidal ideation that is either occurring in relation to these symptoms or independent of them. And as we mentioned before, patients may have symptoms that are related to being having withdrawal from alcohol, nicotine, or any other substances that they may be using frequently. Anxiety is usually picked up as restlessness, as worries, as repeated reassurance seeking from the doctors to ask whether they're going to get better. The likely themes for these symptoms are usually going to be around their own wellness or the wellness of their family members. Insomnia is common, which is a difficulty with getting sleep or with staying asleep. Depressive symptoms in terms of becoming hopeless or thinking that they may not get better or being sad, tearful, symptoms of that sort. Suicidal ideation, as the term suggests, is our thoughts of self-harm. Over the course of the last year, there have been reports of patients actually completing suicide while in COVID hospitals. So this is obviously something to be very careful about. And withdrawal symptoms, I don't have the time to go into in great detail. It is just that it is useful to recognize these and probably prescribe appropriate medication for them. The general principles of management are that patients who have a previous psychiatric illness are likely to be at increased risk for development of these symptoms while in hospital. As far as possible, psychotropic medication should continue. We should not routinely stop antidepressants or antipsychotic medication for someone with an established psychiatric illness. However, medication may require modification. The SSRIs, I will just highlight, are agents that are used for the treatment of depression, commonly escitalopram, sertraline, fluoxetine, fluvoxamine. These are powerful antagonists for powerful inhibitors for our drug metabolizing enzymes, because of which they may counteract or increase the action of other medication that you're giving, particularly antibiotics or steroids, and this may have an impact on the patient's overall welfare. This must be looked at. You must also be aware that insomnia, anxiety may actually be features of hypoxia or a worsening pneumonia. As we said before, patients do become tachypneic and agitated when they are anxious. They also become tachypneic and agitated due to air hunger. It is useful to make sure that you have done a proper clinical assessment, particularly for the primary condition the person is in hospital, before coming to a diagnosis or an impression of anxiety or insomnia. Now, in this population, for someone who does not have a psychiatric illness, which is likely to be a large part of the population that you're treating, you should be aiming only for short-term symptomatic treatment. These patients probably do not require longer-term treatment with an antidepressant or some other agent. We should be trying to give minimal medications that are useful to bring down symptoms and keep the patient calm. So what I would recommend here is that we talk to the patients, give them adequate information that may be in itself sufficient to manage the patient's symptoms. A conversation with someone who seems to be an authority, seems to understand the illness, may go a long way to control symptoms. Where possible, provide the patient with access to near ones and leisure activities so that they're not only thinking about their illness. If necessary, lorazepam 1 milligram may be prescribed to provide sleep and with for anxiety. I put that star mark there because lorazepam is a benzodiazepine. Benzodiazepines can potentially cause respiratory depression, which may manifest as a decrease in pulse oximetry values for the patient. However, by and large, patients who have mild illness or even mild to moderate illness will probably tolerate a short course of benzodiazepines without any difficulty. Given that we are prescribing this agent, you should, however, make sure that you are monitoring their SpO2 values immediately after. The other side effect of lorazepam could be sedation. That should also be watched for. If this does not seem to be working, it would or if you are seeing a dip in SpO2 values, it makes sense to stop the lorazepam and get a psychiatric consultation. For those of you who do not work in this hospital, AIIMS Rishikesh has a telepsychiatry service which can be accessed. If you can call us, we would be happy to answer questions in relation to how to manage these symptoms. I think that is probably my last slide, Dr. Puneet. I am happy to take questions in the time that's remaining.
Yeah. Thank you, Dr. Vijay. So Dr. Vijay will be happy to answer questions regarding any kind of drug use or any kind of psychotic symptoms or psychiatric symptom, anything which comes up in management of COVID-19 admitted patients.
I think there's one question from Dr. Panda. Let me just read it. Yeah, so he says, thanks for giving us a basic bedside approach. Can we start using some checklist in its simplest form for recognizing delirium, anxiety, fearfulness, insomnia, and depressive thoughts questionnaire, but taking one major point for each, like you told, inattention as a major feature of delirium. This checklist will be so simple that without training, even an NO or MBBS graduate could use it. Right. So as I said, the confusion assessment method for delirium is very easy to use. If you understand what it is going about assessing, which is what I've tried to tell you, it can be used by someone on the ward routinely. It is only 4 points. Typically you would be looking at inattention and the other features, which are not very difficult to pick up. For anxiety and depression, there are structured instruments. For example, there's something called the PHQ-4. That's the Present Health Questionnaire 4. That's 4 items that picks up both anxiety and delirium, which can therefore be used as a screening tool. Insomnia can again be picked up using something called the ISI. Right now I'm blanking on the full form for that. That's something, Insomnia and Sleep Index, I think, which is again 4 questions, not very difficult to perform. Both of these are available in Hindi. I hope that answers Dr. Panda's question. If there are any other questions, I don't know whether we have time for any more questions, Dr. Puneet. I leave it to you.
We can take up the questions if anybody puts up in the chat and you can answer it, or maybe you can just tell us about the number of telepsychiatry so that
yes, that's true. Can I just put it in? I'll put it into the chat window as well.
That will be good.
But the number, in case anyone wants to note it down, just a second, I keep forgetting it, is 9084976174. 9084976174. Right. So this number, you at least between 9 and 1 every day, you would be able to access a trained psychiatrist who would be able to answer questions about any of these conditions and would probably be able to guide you in treatment.
So I think people can always check the for drug interactions. They can always go online and check whether the drug is interactive about any potential drug interaction. So there are many online tools which are available free of cost for checking drug interactions. So I hope that summarizes the whole issue of psychiatric issues and looking at it from the bedside perspective. So I would thank Dr. Vijay for giving us this talk and in a very simplified way. Uh, and we hope that this will improve the management of COVID-19 patients in future. Thank you, Dr. Vijay, and thank you.
Thank you, Dr. Puneet, for giving me the opportunity, and the Vice Dean's office, I guess. Thank you so much. Goodbye. I hope it was useful.
Thank you.